to one of the different WhatsApp chats I'm in. So people are already answering what they think it is, blah, blah, blah. And yeah, so here's my response. You can see it. There it is. And here's the EKG. So let's talk about this EKG right here. No, you can't see it because this thing has this, blocking the periphery. So what I want to do with this video is I want to talk about this EKG. So first of all, remember that we see patients. We don't see exams. We don't see labs. We don't see numbers. We have a patient in front of us, and this EKG comes from a patient, and that's our main interest. What does this mean? It means that you have to see this electrocardiographic diagnosis in the context of the patient's symptoms or manifestations, because it doesn't make sense for us just to look at EKGs and give a blurred out diagnosis, and we don't even know what's the age of the patient, what does the patient have or not, symptoms, etc., etc. But as you may know by now, if you are a medical resident, student, physician, or in healthcare, you will receive many EKGs through your different messaging software, and people will be asking you, what do you think about this? Sometimes it's a doctor, sometimes it's a friend, sometimes it's someone that has no idea whatsoever what they're seeing right here. So let's talk about this EKG quickly. I'm just going to focus on the electrocardiographic diagnosis. The idea for this video is in order for us to walk through a possible approach and the importance of being systematic. So we have to be organized. Every time you see an EKG, you have to maintain the same organization, because if you're not organized, you won't, you might get the diagnosis, but you may be missing very important information. So advice number one, when you get an EKG, pause, breathe. You don't have to give your diagnosis in the first 5 seconds after you received it. You can take a breath, and you have to actually take your time to see this. This is a new language. EKG is a new language, and you just shouldn't disrespect the language. You should give it the importance it deserves. That being said, let's go into this. Okay, so I don't care if you like seeing the EKG from backwards to front or front to backwards. Whichever you use, just be sure to be systematic. You have to make this a habit. So once this is a habit, you won't lose important details. So actually, I don't know the real diagnosis. I'll keep you updated. But this is my take on this EKG. I've seen it for approximately 5 minutes or so. That's like the usual time I take. So when someone shows me an EKG, first thing I ask is, okay, who's the patient? I want to see the patient. If they're in front of me, if they're in the room. Okay, so I can see their faces. I can see if they have symptoms or not. If they're not in the room, I'll ask the person that sent me the EKG, can you please give me some context? Okay, so after that, I'll look into it. But for this EKG, it's the usual EKG that is just sent out to a group chat with no other information whatsoever. So we can also make some good learning points out of that. So let's start seeing this. Okay, so first of all, systematic. So some people will start off seeing the heart rate. Others will start off seeing the rhythm. I don't care. Just be sure to see everything. So let's start off seeing the heart rate. Okay. So we can see it right here. There are different methods for heart rate. I'll use the fast one, which is just using the big boxes. So this would be, let's look for one of these vertices that are just on the line. This one right here. Okay, so from here to here, 300 beats. From here to here, 150, 100. Okay, 100. Does this look similar to the others? Okay, almost 3 boxes, 3 boxes, 3 boxes. Yeah, it's consistent. We already know the heart rate. The heart rate is 100. Okay, the patient is tachycardic. 100 is the limit for tachycardia. Actually, algorithms, ACLS, say that tachycardia is above, let's see, well, 120. They go above that. That's not what I wanted to actually say. I wanted to talk to you about the usual ranges for heart rate were made in people in the army, which don't represent that well the general population. So it has been said that there could be a reappraisal to what the normal heart rate should be, stating that it could tachycardia could start above 90 beats per minute. So if we have 100, yeah, that's tachycardia in general terms. You won't tell a patient you're in 100. Let's wait and let's see if you're in 101. I'll call it tachycardia. If you're in 99, you're not in tachycardia. So always in the context of the patient. But if the patient is in rest, 100 is probably not normal for anyone, right? Okay, so patient is tachycardic, and we saw that it is consistent. Here, I recommend that if you have this printed out, you get a piece of paper, and what you'll do with the piece of paper is you'll mark it right here, the vertices. Look for 2 vertices of the QRS. Look at my mouse right here. Here's one, here's the other one. So you'll put this right next to those 2 vertices, and you'll mark a point on each of those 2 vertices, and then you'll move the paper this way and that way to see if the vertices of the other QRS complexes are in line with the vertices you just drew. Why is that helpful? Because that will tell you if the QRS, if it is rhythmic or arrhythmic. That's a very fast way of knowing, and that's a great way of determining patients that might have atrial fibrillation. Always do that, because sometimes our eyes may miss some details. But in general, this is very consistent. So patient is tachycardic. The ventricles are rhythmic, because remember that we have atrial rate and we have ventricular rate. We are saying here with the QRS that the ventricles are rhythmic. Now, what about the atria? Here you have a P wave. Let's see where can we see the P wave the best? Well, yeah, we can actually see it pretty well right here. This is the P wave, this is the P wave, and all of the P waves are following a QRS, are before the QRS complex. So there is consistency. So with this, we are ruling out that the patient might have a complete heart block or an advanced atrioventricular block. Okay, but we are seeing something interesting. Okay, so now we're focusing on the P wave. We're seeing that the P wave is a little longer. So let's see a P wave. Here's a P wave. If you're not sure if this is the P wave, go directly upwards. So use the piece of paper again to align, or a ruler to search this same deflection to see if this reflects the same thing in other places. So right here, yeah, this is effectively, this is the P wave. So look at the P wave. It's a long P wave. The usual PR interval is 0.12 to 0.20 seconds. This looks longer than that. 0.20 seconds would be 5 small squares. And this is longer. This is, let's see, this is in the limit. I could say, just in the limit, I could say this is probably a first degree AV block. So interesting, we already have that the patient is tachycardic, in rhythmic, that there is a long PR interval, meaning that the patient has a first degree AV block. And now let's move on to seeing the morphology of the P wave. The morphology of the P wave is best seen in 2 different in Spanish it's derivadas. In English, two different places of these 12 derivatives, which ones are they? Yes, D1 and D2. So if you see D2, this P wave looks a little like elongated. You almost can see a couple bumps on it. And the semiology of EKG says this looks like a P mitrali, or mitral P, meaning that the left side, it might be enlarged. If you go to V1, it looks a little peaked right here. Don't get confused with this right here. This isn't part of the P wave. This is the T wave. How do I know that? Because you draw a straight line from this one downwards, and you see that this is the T wave. This is part of the T wave and not the P wave. So this is the P wave, and this is important because if this was the P wave, it would be telling us that there's probably biatrial enlargement. But based on this being the P wave, it's consistent with it probably being a left atrial enlargement. Remember that electrocardiographic diagnosis isn't 100% sensitive or specific. So in general, this might look strange. When you add more things up, probably the probability of there being a problem increases. But if you just found this and nothing else whatsoever, yes, sensitivity will go down. But we're finding a couple things, so this is telling us that this isn't a normal EKG. Okay, so we have those characteristics already. Now let's go on to see the QRS complex. The QRS complex, let's see, we have to assess different things. Number one is how is it a broad QRS complex, or is it a normal QRS complex, which is 0.08 to 0.10 seconds? It's more than that. It looks more than that, and it's actually a broad. Look at this QRS. So let's try to magnify this right here. Okay, very nice. 1, 2, 3. This is 0.12 QRS complex. That's a complete block. So incomplete block would be from 0.10 to 0.12. This one is 0.12. This is a complete block of what? We have two branches. We have left branch and we have right branch. Okay, so now let's go see this first vector in V1 is positive. That is usually telling us that it's not a left bundle branch block. Let's then go to see V6. You see an S, which is very long. In Spanish, it's called empastada, but in general, it's just lagging. It's lagging to go up. So this is a complete right bundle branch block. What else can help you determine right versus left? The mnemonic for right, there's two-word mnemonic which will help you figure out if it's left or right. It's a name, William Morrow. So William, in the middle of William, you have left, double L's, it's left. So we're not talking about left bundle branch, we're talking about the Morrow, the last name. In the middle of the word Morrow, you have two R's, that's right. What does this mean? That Morrow starts with the first letter will be V1 or V2, okay? First letter is an M. So this looks like the Mickey Mouse ears, the QRS, Mickey Mouse ears going upwards. Okay, so that's the M in Morrow. And then the W will be V5 or V6. Yeah, does this look more like an M or a W? Like a W. Okay, let's see the Morrow, the M right here. This is the M, okay? Two deflections, boom. And also, there is R, S, R prime, and then the Q, R, S. See, this is complicated. This isn't simple at all. That's why there is a subspecialty called electrophysiology, and put two electrophysiologists in a room and you'll see that this isn't simple, and one will have one diagnosis and the other another. So we have to try to understand the basics. This isn't that basic of an EKG, but this looks like the M in William Morrow. Let's go see V6. Right here, this looks like a W. Look at the W right here. So in general, William Morrow helps us determine morphologically. But if you also add to this that in V1, what you should be seeing is, what you see is the right ventricle more in V1, left ventricle more in V5 or V6. So if you have right bundle branch block, you will see more of the manifestation of the right. It is somewhat counterintuitive, but this is the way I learned this. So if you have a right bundle branch block, imagine you're on your way to work. So you're driving down the usual road. You go always on a daily basis for a year to work. Will you remember your drive to work after 600 days of going through the same street? Probably not. But let's say there is there's some problem. There's an accident. There's several accidents. There's people lying there, and you'll have to go around the usual route. Will this day be more memorable? Yes, you will remember it more because you had to get out of the usual habit or your usual highway. So when you have a right bundle branch block, what it means is that the right road to the right ventricle is obstructed, clogged, and all that. That means you will remember it more. That means it will take you more time to get to that right ventricle. And if it takes more time, and if it's harder to get there, you will see more of it and you will remember more of it. So in general, right bundle branch will be more memorable on the right. So V1 and V2 will probably have more of a positive deflection, and V5 and V6, which should be more representation of the left, are actually also showing us the right, because V5 and V6 are showing us very large S waves. The S wave is actually the manifestation of the right ventricle, because you're seeing the opposite what you usually should see. You should usually see a peaked R wave in the last derivatives, V5 and V6. You're not seeing that. You're seeing predominance of a negative deflection. So I'll make a video explaining this a little probably, but let's move on. So this patient has a complete right bundle branch block. What else can we see? We can also go and see where is the axis of the QRS. Where's that vector of the QRS heading towards? So in general, when we have a right bundle branch block, we'll have a rightwards axis instead of a leftwards or normal. Same happens with left bundle branch. It will have a leftwards axis. So in this case, where is the QRS vector going? So for that, we can use the simplest of them all to see where the vector is. You see D1 and you see AVF. This is D1. D1 is negative. So just using the quadrants to know where this goes, if you make the Einthoven's triangle, or if you have it in your mind, D1 is negative. So let's see. No, that's something wasn't adding up. Yeah, there it is. Okay. D1 is positive. Okay, so we're going the usual route. And AVF is negative. So we're going upwards. So we're going, if you write it down, we're going right to the right and upwards. That leaves us in the quadrant of 0 to negative 180 degrees. And we're talking that 0 to negative 30 is normal, but negative 30 to negative 180 is negative, which means left shift. So we have a right bundle branch block with a left shift. Something else is going on here. This could be ischemia, or it could also be a left anterior fascicular block, which in this case, seems to be so, is probably so, because one of the characteristics of left anterior fascicular block is that the axis is to the left. So we have another probable diagnosis right there. And there's one last one which is very important. You cannot forget it, which is this one right here. Look at the ST segment always when you're seeing an EKG. This looks a little, it's higher from the isoelectric line. V5 is probably, you can't even see it because there was a change in the isoelectric line. V6, not much. Let's look at other places. Okay, D3 definitely has an elevation in the ST point, or the J point, which is actually that conjunction with the S and the T in the T wave. And we also have that in ABF, D3, and D2. Those three derivatives are talking to us about the inferior leads. This is important because if you have just a manifestation in one single lead, that's the name, lead, instead of derivative. If you have one lead that has an alteration, that doesn't mean much. But if you have several leads that are pointing in the same direction, that is more significant. So these three leads, 2, D2, D3, and ABF, are inferior leads. This talks about, could be right ventricle, or could be also the base of the heart, which is like the inferior portion of the left ventricle. So that's something you should watch out. So when I saw this, I asked myself, what are the symptoms of this patient? Is this patient in pain? Does this patient have any ischemic equivalents? Because this is important. Because in the context of a right bundle branch block, you should be able to interpret ischemia without any trouble. But remember that we have a left anterior fascicular block that could actually impede the repolarization, impede a correct interpretation due to the repolarization. But always be very mindful of this. And since this is inferior leads, and this could be right ventricle, I would go on to do the posterior leads, which would be V7, 8, and 9. And I would also do the right leads, which would be basically turning them around. Most significant leads in the right would be V3R and V4R. The rest doesn't have much clinical significance. So that's it. This is my diagnosis. This is what I said in the end in this chat, and I think they already answered. So my answer was tachycardic rate just above 100 with advanced conduction system disease. Seems like pre-fascicular block, because first degree AV block, complete right bundle branch block, and left anterior fascicular block. I said I don't like the ST elevation in the inferior leads in the context of right bundle branch block, but the left anterior fascicular block can produce this finding. Important now to know if the patient has chest pain or equivalence. And the person who shared the EKG just answered and said troponins 5.2 and chest pain radiated to the left arm with ejection fraction of 15%. So we didn't miss it. We got it. And remember to be systematic with your approach. So after the QRS, you have to go on to see the ST that we already talked about it, and last but not least, the T wave and the QT interval. So I actually didn't measure the QT interval. Remember that you have to correct the QT interval, and I made a specific video on how to measure the QT interval in my YouTube channel. I'll leave you the link to that video maybe at the end of this video, or in the comment section, in the description section in my YouTube channel. I'll also post this in Instagram, and that's it for this EKG. Hope you liked it. Let me know any questions. Let me know if you don't agree with this approach, and see you in the next one.